Given what are you going to talk about, so it's what not to do exactly. So these are 10 gospels of truth, as I call them. So this is a 16-year-old with a sclerotic lesion over the left inferior pubic ramus, as you see on the X-ray. This was assumed, and that was a classical example of assumption, to be an osteochondroma. It was excised, but it came out to be a chondrosarcoma. Another 9-year-old, and Manish has kind of pointed out that very brilliantly. So 9-year-old sustained a fracture shaft of the right femur following a fall from a bicycle, assumed to be a post-traumatic fracture shaft of the femur. It was fixed by 10 nails, till, of course, the actual tumor manifested itself, and it turned out to be an osteosarcoma. An adolescent presented with pain and swelling upper right tibia, assumed to be a giant cell tumor. No biopsy was done, underwent curettaging and cementing, and of course it turned out to be a giant cell rich osteosarcoma. So what are we assuming? The first law of musculoskeletal oncology is never assume, and Manish has absolutely brilliantly put that in that video, because you have an us, you and me in there in the assumption part. So never assume in musculoskeletal oncology, that's the first rule. Now, if operating on a bone tumor without a biopsy is a mistake, not doing the biopsy correctly is a sin. And we were just discussing this in the morning, that in high volume centers like ours or like where Manish works, we see so many patients who are interfered, particularly biopsies done. So in fact, at the institute where I work, 8 out of 10 tumors present to us with a wrongly done biopsy, and that's a very modest figure. So this is one message that you can take home, is to either do the biopsy correctly or send it to the center where the tumor is going to be treated. Now, of course, poorly done biopsies, they turn simple surgery into nightmare. For example, this was an osteosarcoma, a diaphyseal osteosarcoma, with a biopsy which was right onto the tumor. So you have to take it out, do a flap. She was lucky that the flap, didn't get infected despite chemo and everything, and she made it through. So the second rule in oncology is that never do a biopsy if you don't know how to do one. That's important. Now, there are certain things, therefore, that you should know what to do, and that's the logical sequence of any lesion that presents as a suspected malignancy. So first thing is that you know the local radiological extent. You do the local investigations, either it be an MRI or, as Manish said, with contrast, or a CT scan. Then you try to look if there is any distant metastasis, and finally, you try to know the histological grade, that is, you do a biopsy and get a histopathological diagnosis on it. So once you're doing a biopsy, before doing the biopsy, your imaging should be complete, and that is what you should do. Now, this is a 12-year-old boy with a pain left hip presented to us with an MRI and is diagnosed as chronic osteomyelitis of the acetabulum. If you can see in the picture, on the posterior column, you see there's a bit of an edema, a bone edema, but this is extensive bone edema. Now, actually, when you do a CT scan, you find that there is a nidus, which is again taken up on the bone scan. So this patient did not have an osteomyelitis or an osteosarcoma, as it might assume. This is just a plain osteoma. So the third rule in musculoskeletal oncology is choose the correct investigation. So not every bone tumor will require an MRI unless you are sure that you want to do an MRI for a particular reason. So the investigation of choice for an osteoma is a SPECT or a bone scan combined with a CT scan. So whether you do oncology or you don't do oncology, remember you should always have an all-round view, because all-round view can be life-saving, and it's important that you have an all-round view of the tumor. Now, this was an 18-year-old boy treated with an intramedullary nail for a fracture. Of course, this nail is not very nicely done, but still, this is not the question that I'm worried about. So when you get an X-ray of the knee done, you see there's a big tumor over there. So this was a pathological fracture. This was an osteosarcoma, which had caused the pathological fracture up there in the femur. They had not scanned the knee, and therefore they missed this tumor. So this is important, and of course now that this has happened, so all is contaminated, we have to take it out and put a total femur, as Manish showed in his cases. So, the fourth rule in oncology is to have a complete all-round view of the lesion. This is very important, because you want to know. So what we teach our students is the ABCs. So as you have ABCs in BLS courses or in ATLS course, you have adequacy, see the bone, and with the S, see the soft tissue. So these are ABCs, and S and C is the cartilage, of course, that is the joint. That is how you teach them to see a bony lesion, X-ray of a bony lesion. So this was a 13-year-old, I'll just come to these, why I'm talking about these ones. So 13-year-old girl with a high-grade osteosarcoma of the upper tibia, the expandable prosthesis was done, but she recurred. And when you do an amputation, get a histopathological report, you find that the margins were not free of tumor at that time, in the first go. Another patient, osteosarcoma of the proximal tibia involving the knee joint in a 17-year-old boy. So this is an extra-articular excision has been done. The knee has not been opened up, and the tumor has been removed with both upper end of tibia and the lower end of femur. And when, of course, post-surgery, you see that there was tumor inside the ACL going in there. So actually, what I'm trying to show you is that margins can be contaminated, and I'll tell you why. So this is a 16-year-old, correctly diagnosed as chondroblastoma, curettage bone grafting done outside, but the tumor recurred. And again, the margins were positive in this patient. So if you read some of these important papers, you find out that local recurrence is directly linked only to one, statistically linked only to one aspect, and that is contaminated surgical margin. So the fifth rule in musculoskeletal oncology is to have a clear oncological margin during tumor resection. Never compromise on your margins. So if you're thinking that the tumor margins are positive, it's better to amputate rather than try limb salvage surgery. This is a 7-year-old boy with a malignant mesenchymal tumor of the forearm. He developed gangrene over there in the tips of the fingers following tumor emboli into the digital vessels. I'll just tell you why I'm talking about these. A 21-year-old survivor, she had this surgery done at the age of 14 years for an osteosarcoma of distal femur, presented to us with implant breakage, which was treated. So, and of course, these patients who undergo revision of their prosthesis, this patient underwent third revision in about 20 years. So, the kind of blood loss you have, the kind of medical issues these patients will have. So, the sixth rule in musculoskeletal oncology is that you can attempt tumor surgery only if you are capable to manage its complications. And this is very important. So what I'm trying to tell you is that try to do oncology in a setup which has got all the necessary infrastructure to manage that big resurgery. Now, how not to do a reconstruction in a tumor after a tumor excision? Now, reconstruction depends on multiple factors. So there are patient factors, there are surgeon factors. Reconstruction has got socioeconomic implications, particularly in this country. So based on that, you can have a biological reconstruction, you can have a non-biological reconstruction. So once you've removed the tumor, you're really not sure how you're going to reconstruct. So don't do it the wrong way. So this is an adolescent with a lytic lesion, diaphysis of the right tibia. There you see, this was what was done. This is what it should not have been done. So nail put in without just a little bit of curettage over there. This is exactly what not to do. And then the patient comes to you with this full-blown picture, and that's an adamantinoma, which has been taken out, a vascularized fibula done, and there you are. So the biological options should be very clear to you. So there are biological options, particularly in this country, for example, using allograft with fibula. For segments, defects which are less than 7 centimeters, we use non-vascularized fibula, and you can use vascularized fibula if the defect is much more greater than that. For example, this child, this is the same X-ray. So you see that we have used moslicized allograft along with the fibula. And of course, we also do arthrodesis. It's not that bad an option. So you see this is a turnoplasty. There is a union over there. So what you do is you remove the tumor. This is the upper end of tibia. And then you take a sort of a coronal cut into the tibia and put it back into the femur, arthrodesing it. So he does have a limb salvage done because of his socioeconomic status. He had to go in arthrodesis. That's also an option. And of course, then you have the good option. You have the prosthesis in there. So that's a 16-year-old osteosarcoma for an upper left tibia. You can see that we've done a flap also, which reinforces the extensor mechanism. So, the seventh rule in musculoskeletal oncology is there are no shortcuts in reconstruction. So when you're doing a reconstruction, make sure that your reconstruction lasts as much as possible. Possibly it's biological, and if not, then of course you should be counseling the patient how to go ahead with it. Now, never say never till you really know. So this is an infantile fibrosarcoma of the forearm in a 3-month-old baby, which is a very common tumor, not a very common tumor, which is a tumor which happens in infants. Look at the amount of destruction it's causing, but that's how it looks like after resection. So it's not bad. This baby was advised amputation somewhere else. Or, for example, this patient, a 14-year-old with pain in the knee, and there was a diagnosis of osteosarcoma outside without a biopsy. This actually was a myelorostosis. So the 8th rule in musculoskeletal oncology is never conclude till you are sure. And of course, that's biopsy again, bringing it back from 1 to 8. So always talk to your patient who has got a tumor, a suspected tumor, with caution, and you should know what you're talking about. That's an 18-year-old female with osteosarcoma of the distal end of femur. There's no response to chemotherapy, and you see there was involved in neurovascular bundle, a pretty long segment. There you see the vessel going right into the tumor, so we had to amputate this patient. There's an Ewing sarcoma of the calcaneum, limited reconstruction options. We have started doing what we call as the ECRT of the calcaneum now, but previously we used to do amputations. He's doing pretty well with that amputation. So what I'm trying to tell you is, and that is the 9th rule in musculoskeletal oncology, never hesitate to amputate, because that's important. That's in part of the musculoskeletal surgical training. And we always not try to do a limb salvage if that is at the cost of other things. A large number of tumors that are referred to us, a very small percentage of them have adequate pain relief. This is important to a group that I'm talking to, the pediatric orthopods. So the one thing that you should always remember is that never leave your patient without pain relief. And that's the golden rule, I would say, the 10th one. Because these are small kids, they need pain relief. And this is important, particularly in context of this country. So the conclusions are that evaluation of a patient with bone tumors should be complete and sequential, as I showed you how it should be done. The management strategy should be planned and executed by a team, not by an individual. None of us are important, or all of us together are important. Reconstructions can fail, that's not a problem, but surgeons should not fail, and that's important because if you're reconstructing it in a manner that is going to fail, then you are actually failing. And have the heart and mind to deal with complications. This is an important part of musculoskeletal oncology. And finally, we are living in the limb salvage era, and I'm finishing this talk with the word amputation, but never hesitate to amputate, because that's an important thing, that you're causing more misery to the patient. And try to read what this gentleman, Edwin Toffler, the author for Future Shock and Third Wave, he said, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. Thank you so much for your kind attention.